Thank you very much. This is, and thank you guys for the opportunity to talk in this panel discussion. My name is Alex Chang. So we have a few questions here that we came up together that we thought would be interesting and promote lots of conversation. And it seems like a very, very talkative audience with important topics. So I think, at some point we'll ask people to please weigh in. But if you feel like you have an excellent point you want to bring up, feel free to raise your hand. So I'm a nephrologist by training. I have been interested in obesity and kidney disease for the last 15 years. Interesting, when I started doing this research, people would kind of be like, okay, so that's interesting, but how do you know that helps the kidney? And to me, it seemed very obvious that you have obesity, you have diabetes, you have kidney risk, and that weight loss should be, something that should be discussed. Of course, back then we did not have the drugs, and now we do, and there's lots and lots of interest now. So I think, I'm not boarded specialized in obesity medicine, but I have come around to doing lots of work in research and then clinical cases of obesity and kidney disease. So I'm going to provide a sort of a nephrologist perspective. I was also involved in our ASN health guidance on obesity, which will try to provide some practical guidance for nephrologists currently, because, as you know, the medicines are out there. Sure, some of them have not been studied exclusively in kidney disease outside of diabetic kidney disease, but they are out there, and nephrologists are not sure what to do. And another part of the activity I've been doing has also been organizing a similar conversation with the National Kidney Foundation. And we also had a lot of different disciplines involved there with dietitians and obesity medicine, nephrology. And if you get the dietitian's perspective, it's interesting because they basically will tell us, nephrologists don't prescribe obesity medications. They're not involved at all in the US. I mean, very rarely, probably. And a lot of times it's coming from the dietitians are not directly involved in the care. So I think one of the points I wanted to make in discussing this outside of the access and the cost of the medications issue is that we're not doing as good of a job in interdisciplinary care as we should. We have all this in our guidelines. We know in the clinical trials, when they do the obesity trials, they have a very careful dietitian or some kind of lifestyle intervention coach involved in the studies. Of course, that probably varies between study to study, but that's a key component to that, and that's a key component to any obesity medicine specialist's care. So ideally, you have the obesity medicine clinic, and they have a board-certified physician, and they have a dietitian, they have a social worker, they have a psychology involved that can provide any types of care that the patient needs. They discuss all the options. Sometimes the medications is what's recommended along with the lifestyle intervention. Sometimes the bariatric surgery, sometimes they end up needing both in various different sequencing. And I remember for the ASN kidney health obesity guidance, we kept struggling with this figure, trying to come up with some kind of workflow and realizing that, it really has to be very circuitous, where you may end up needing medications, you might need a surgery, you might go the other way around. There's a lot of different ways that each patient, individual, that depending on their preferences, that is important to take into account. Now, in terms of the cost issue in the U.S., for diabetes, of course, most of the insurance will cover use of GLP-1s because there's a strong evidence base, and that's incorporated into our KDIGO guidelines, of course, and lots of people have been involved in that effort. I think for the non-diabetic side, it's very tricky now because the insurance companies are seeing in the U.S. that their costs are going up because of GLP-1 use. This is what they will blame it on when they talk to us about it. And so they're only covering it for certain conditions, and it may vary between insurances. It's very challenging to get coverage. I believe Medicare now covers obesity with cardiovascular disease per the SELECT trial inclusion criteria. And so I think some of the insurance companies are starting to adopt that, which means that if you have an obese patient with a BMI of 45 who doesn't have diabetes but has FSGS and chronic kidney disease and clearly needs weight loss, and they have NASH cirrhosis and they have sleep apnea, it doesn't really matter that you can't even do a prior authorization or argue with anybody on the phone. They'll just immediately say that it's not listed in their coverage, and it's a very big problem. And when you talk to patients outside of the ones that we're seeing, a lot of them are actually going to these telehealth programs where a doctor is, I don't know where they're getting the medication, but some compounding pharmacies, and the problem with those compounding medications is that they're not FDA. Nobody's checking for safety issues and all that that you get with the FDA. So that's another huge complexity with this issue. And then of course the availability and having to switch on and off medications and navigating that is very challenging for patients. So I'll stop there, and I'm sure you guys have plenty to discuss.
Thanks. Thank you. So you've heard cases, you've heard the overall evidence, and we've had some excellent talks in the morning. So I'm going to take a slightly different approach here, and I will posit to you that while we think of obesity and kidney disease as an issue, and we've discussed a lot of data and possible interventions, the phrase that hasn't come up since morning is considering this as a public health issue. And I bring this up from the lower middle income country perspective because a number of therapeutic options that we are talking about here are not likely to be available in those parts of the world, and I don't think they are going to be available in the foreseeable future as well. Even if they are available, the access will be limited to a small affluent minority in those countries, of which, of course, there are individuals, and there will be a market. And so therefore, pharma will market those drugs in those parts of the world as well. So I present to you this approach that perhaps we need to start thinking, and there was a bit of mention about the malign influence of the industry, and that's something that I think Dr. Sattar, you mentioned, and that's an important bit for us to consider. And we should see what are the socioeconomic drivers that are leading to a rise in obesity. We will have some of those discussions more fully in the breakout groups, but we do need to go back and talk to the communities and see what is it that is really driving up the rates of obesity, driving up the rates of diabetes, kidney disease, hypertension, etc. And consider them as a group of conditions, multiple long-term conditions rather than individual conditions, whether it is diabetes or kidney disease or obesity for that matter. And how do we develop a package of interventions which is rooted in local knowledge, which takes into account the values and preferences of the society in which we are trying to implement the solution, and utilizes the community knowledge that exists and working with the community to find a solution. There has been an issue of diets, and there is emerging data from many of these countries that in contrast to high-income countries, obesity is primarily a problem of the more affluent and lower-income countries, and as the level of income goes up, the level of obesity also goes up, and potentially increasing the access to fast foods and processed foods, which is a novelty for many of these people, certainly, as their income goes up. So just understanding that kind of nexus, which is not intuitive, is also important. So working with those communities, understanding their indigenous knowledge, their indigenous food systems. There are many countries which have public distribution programs which try to ensure food security for those populations. And so the goal is different. The goal is simply to give them enough calories, but how can we work with authorities that manage those programs to introduce diversity into the food distribution system to make sure that the kind of food that they get is conducive to the type of health outcomes that we are desirous of is also important. The other elements that we should also think about, we talk about exercise, but is the local environment conducible for exercise for these individuals? The built environment in many of these countries, many of these towns and villages isn't conducive to exercise, even walking outdoors, etc. So I think that the conversation needs to be had with policymakers. So in terms of the other socioeconomic factors, when we talk to people, we have to also first listen to them and try to understand what are they understanding when we go and talk to them about interventions, because sometimes they have more pressing issues that they might think is more important to them. And the final thing I would say is that we need to think a little bit more about the real upstream drivers of the development of these multiple long-term conditions, which include obesity, diabetes, etc. And that might include things like maternal malnutrition and early childhood nutrition and so on and so forth. I think these cases are important, but when we talk about availability of GLP-1 agonists, the answer is very short for many parts of the world, because they are not going to be available, and we have to fall back on these other types of solutions that we have to think about, and they are less individual focused but more societal focused.
So we can take some questions. I think this has brought up the real importance of societal factors, environmental factors that affect both the risks for obesity and adverse outcomes, and then also the opportunities for intervention that vary in different locales. So are there questions on the far side? It should be red.
There is one.
Oh, there's a.
You have to switch off your.
Yeah, can I have a
Well, just could you switch, I think it could be on, you want to,
okay.
chance to, question over there, there we go.
Now yes,
Okay.
sorry. It was late. I'm happy that Vivek raised the topic regarding lifestyles and what I say a public health problem. The World Health Organization have raised this topic regarding primary prevention for obesity, but it looks like the world has lost this fight for primary prevention, but I think it still has to be raised awareness regarding lifestyles. It's a very difficult topic, lifestyles, because it's that what get us into this problem. Less physical activity, worse diet, but when you look at the rates of obesity in the world, Europe has the lowest rate, and I always think that it is because the physical activity is greater in these countries because of one thing, not because they exercise more, because the transport system is better. And World Health Organization has frequently pointed out that physical activity that is related with transportation or public transportation is better because it's something you need to do every day. You cannot change lifestyles unless you get public involvement, political involvement regarding the policies in the countries. And thinking, of course, thinking regarding drugs that will make you lose weight is like, for obesity problem, is great, but it looks somehow for me that is the same like saying that you will beat CKD with strong dialysis or transplantation programs. You are looking for the solution of the biggest problem. So I think in these 2 days there should be a little place for raising awareness of the public problem and the ways that the countries could solve or could look to the primary prevention too, because if not, in 20 years more, we will have not 50% of the population, 12% of the population with obesity, but probably 30, 40%. And we are going to probably begin with something that has begun, that is losing life expectancy because of this problem. Vivek made me think about it.
Those are really very important points. In the front.
Thank you, Magdalena Madero from Mexico. Thanks for these perspectives. You know, coming from a low middle income country, I could tell you that Mexico was the first country to implement the tax on sugar sweetened beverages. And it's about 1 peso for each liter of sugar sweetened beverages. And this started in 2014. And I think these are, I mean, we have a huge problem of diabetes and obesity in Mexico, of course. And, you know, because access to all these GLP-1 agonists would not be available, as Vivek said, for our country, I think these policies that have been implemented may translate in better outcomes long term, but they have to be policy, health policy changes. We also now have a huge labeling on the foods where it says excess calories, excess sodium, excess whatever, and they're huge. And, you know, would this translate in better outcomes? We don't know yet, but at least, you know, this taxing from the policy, from the health policy may impact, you know, outcomes in low middle income countries. So, you know, a few things that we can do, you know, to prevent these outcomes. So that's just one comment. And then just a quick question to Alex, you know, when we have access to these medications, you know, is there any data for going, I mean, I'm very impressed with Maria Jose's outcomes because, you know, with 1 milligram, we usually do not see that amount of weight loss. It's usually between 3 and 4 kilos. So we get all the good outcomes, but not really the weight loss. So is there any evidence, you know, for 2.4 milligrams of semaglutide in CKD patients, and is it safe to go all the way to that dose? Is there any data on that? Thank you.
Well, thank you. I totally agree that the public health perspectives are really sort of missed, and I think, you know, the U.S. is very challenging because you know, lots of political reasons of who's probably in part paying the bills for various things. But to your question, I think for CKD, you know, there's plenty of patients with stage 1 and 2 CKD that are included in the GLP-1 trials and the combo drugs as well, and because, you know, they usually have an EGFR cutoff involved. To my knowledge, there really is not much for like more advanced, like stage 4 or 5. I think stage 3, I think pretty confidently you could extrapolate some things, of course. And I believe there was discussion about how the obesity trials, when they exclude diabetes patients because the diabetes patients are already examined in the original trials. And so in those trials, they lose more weight than the diabetes trials. I think in the diabetes trials, they don't necessarily have the same, you know, lifestyle component to it. How does that extrapolate to CKD? I think we don't really know. So yeah, stage 4, 5, CKD, ESKD, it's really hard to tell. We did try to do a small study, a randomized trial for patients with advanced kidney failure who were in need of kidney transplant but had too high of a BMI for the transplant center cutoff, and it was just a one-center study. And of course, you can imagine we did not meet our recruiting goal, so it was canceled prematurely. But certainly, I think the weight loss outcomes are going to be very interesting to study because these are very complicated patients. They have lots and lots of medical problems, and yeah, as the patient with end-stage kidney disease on dialysis, they lost their appetite and they got sick. Is that because of something else, or is it because of the drug? I think you really need trials to understand that to really get to, is this going to help or not in the long run for the advanced kidney failure patients. So that's, I think, the big gap in evidence.
So we can have time for our patient panel. We'll probably have time for one more question. Over here. I've ignored this side of the room. Over here. Go. Yeah.
Okay. Well, Maria brought up something that I think is really important that we haven't talked about very much, which are societal norms. Like your grandmother said, put on a little weight. And, that's now a worldwide issue. In some lower and middle income countries, it's a sign of being more prosperous. It's desirable. But also, even in high income countries, we've gone so far to avoid body shaming that now obesity has been normalized, at least in the United States. Just to be honest with you, especially in a lot of young women. Like when I was growing up, you couldn't be too thin. And then the problem was a lot of anorexia. I mean, we hardly see that anymore. But there are a lot of young women, particularly from racial and ethnic minority groups, who don't want to lose weight and where obesity is considered attractive. So I think we need to acknowledge that that's going to be another barrier. Not everybody wants to lose weight, and they'd rather be at whatever weight they're at than think about their future. They're more interested in what's going on right now, not that 10 years from now or 20 years from now they're going to have kidney disease or heart disease. But, it really is stunning to me now living long enough to see this turn from you can't be too thin to not only put on a little weight, put on a lot of weight. We like it that way.
Yeah, I don't know that I'm the right person to discuss this, but I will say, and I was not sure if I should bring it up, but on the way here, I was, the airplane, British Airways had different options for TV shows, and one of them was, South Park, the end of obesity, which is totally inappropriate for the conference. But the bottom line for this episode is they're talking, basically satirizing this dilemma where we have the people that have money are able to afford GLP-1s and take medications, and perhaps they don't necessarily need it. And then the people that are poor cannot afford it or get adequate insurance. And then they satirized it to the point where the people that were poor and couldn't afford it were getting a dose of a placebo that basically promoted body positivity. And I think that's kind of a very tricky discussion that really needs to happen. And you could see Oprah Winfrey is a great example of that, right, where she was talking about a lot of things, and then eventually she ended up starting a GLP-1 and is very successful and happy with that discussion. But
One more comment, and then we'll switch to our
It's not a
next
comment
panel.
again, but I thought I'll also share an anecdotal experience, which simply tells us how important is it for us to listen to the society if we are going to be anywhere in a position to be able to influence how they are thinking. And this is a conversation I just happened to hear as a part of a meeting more than 10 years ago in India, where it was about nutrition and diet security, etc. And a speaker was talking about the malign influence of fast food, McDonald's. And a member of the audience got up and said that we have just now started to earn enough to be able to afford to go to a McDonald's restaurant and maybe eat whatever they sell, and you're telling us not to go there. So I think we have to really keep into mind all of these perceptions that exist and then develop responses quite appropriate. I was provoked by what you said, Kathy. Yeah. Exactly, this is what happens in many societies.
Actually, we need awareness of the society, what obesity will do to you, no? Answering a little bit Kate commentary. We need awareness in the TV, in the social media. People is all day long transmuting in social media, and we need that, I think.
Okay, thank you very much to the panel. Thank you.